Dr. Hammill, you're an OB-GYN specialist,
Yes.
and you have other specialty field?
Yeah, I had subspecialty training in infectious diseases.
And over the years, that's gravitated to a specific disease. What's that field?
Well, HIV has overwhelmed a lot of infectious disease providers.
Okay. So you see a lot of HIV AIDS
Yes.
patients?
Yes.
All right. What's the demographic of that populace mostly that you see?
Well, I'm in Houston, Texas, and it does cross all sections of society. I see poor patients from different groups, and I see monolingual patients, I see undocumented patients, and I see patients from what I guess generally would be called Beverly Hills too. So there's a wide range.
Okay. You also work in a clinic here in town called Houston Area Community Services?
Yes, that's a federally qualified clinic. Originally it started as a clinic's mission was to take care of HIV positive monolingual Hispanic patients who had trouble getting care.
Okay. So they came there because they were uninsured?
Yes,
Okay. Is HIV care expensive?
very.
What,
Well, it depends. It's expensive to treat, but if you don't treat, it's more expensive.
what do you mean by that?
Well, patients get sicker, and the sick patients end up in the ICUs dying, costing far more than if they had stayed on their therapy. And patients who are healthy and on therapy work and have jobs and normal lives. People don't understand that.
So for the person out there on the street, if we can get an HIV patient on their medication, they can go back to somewhat normal life?
Yes.
Yeah. And if we don't, then they become
If we don't, then they go down this spiral of getting sicker and sicker, and then eventually dying slowly.
Okay. What are some of the more common causes of HIV?
I mean, because of
Right.
acquiring the disease, the
Yes.
most common is heterosexual transmission in my patient population. I see mainly women, although I'll see men too. And it's heterosexual transmission,
Okay.
not drugs.
Not drugs. Okay. That's interesting. This is a little bit more of a qualified question. Is there sufficient access to HIV treatment in Houston, Texas?
Well, like everything else, if you're very wealthy, you can access things easily. And what happens is many times patients, in order to, they're driven almost to poverty, so then they'll qualify for the poverty provided programs. So the group that's hit hardest are sort of that middle working class person who can't afford the drugs and eventually loses their job, and then they're on the dole. So it is hard to access care.
What would a patient's drug costs be for a year? How much?
At least $10,000 a year, minimum.
for HIV treatment?
Yes.
So if they were to be admitted to an ICU,
Now, if they were admitted to ICU, that's thousands of dollars a day.
That's what I'm
You
getting
can
at.
easily develop a bill up to millions of dollars. And I see a lot of pregnant HIV patients, about 100 a year. And although the transmission rate is low, if you have an infected baby and they don't take their drugs, 90% of those die by age 4, a slow death at the cost of about $1 million.
So not just monetarily, but this is again kind of just a personal question, not just monetarily, but socially. What does this cost us? I mean, how does this affect our society?
Well, I think, if prior to HIV there was syphilis, people were stigmatized with the disease. There was tuberculosis, and there was leprosy. So this is a group of patients that have, I guess you could say, to you, biblical proportions as far as being stigmatized.
Okay, that's very interesting. What are some of the hardships your patients face, the ones who come to HACS, the Houston Area Community Services?
Well, many of them are monolingual, so they have trouble accessing the system because of language barriers.
Okay.
They go in some clinics, people just talk louder in English, the usual approach. The other problem is many of the women I see have families, and they may take their medicine while they're pregnant, but then once they deliver the baby, they'll take care of the baby, they'll take care of their family, they'll take care of everyone but themselves. And then the other thing is, Houston isn't like New York City where they have subways and buses, and You know, if you ever try to take a bus to get to the other side of the city, and then on top of that, you have a baby on your knees and a toddler, it's just getting around is hard, let alone how to pay for the medicines. And then take the drugs. We think it's just a matter of getting the drugs and swallowing them.
Mm. So they face not only the barriers of childcare, but then also transportation, because our transportation system doesn't support our patient populace as well.
It's not easy.
Yeah, it's not easy.
And I've always been impressed that many of my patients will almost crawl to my office, but they make it, especially while they're pregnant.
You know, I'm going to be visiting one of your patients tomorrow.
Yes.
And it sounds like that's kind of been some of her struggle, is she's taking care of more of her children than she has been taking care of herself.
Yes.
What's going to be the result if she doesn't get treatment?
She'll die. She'll leave some orphans.
Yeah. So her husband died in December,
Yes.
and if she doesn't get treatment, she's going to die.
Well, she sort of typifies every mistake that can be made from the system. When she was pregnant, she became discouraged and stopped taking some of her medicine. She has one affected child, who's a lovely child. Then her husband, who was working and provided health insurance for them, he got ill and died. And then she was off her medicines. Now she has advanced disease with opportunistic infections in other part of the body. And, you know, we either make it or break it. The angels are hovering.
So she lost her insurance because her husband was her insurance provider.
Yes.
Through his job. So now she's without insurance. So the only place she can come is Hacks.
Well, she can try to access programs for patients who are uninsured, but there again, you got to qualify, you got to wait. It's a difficult system, although it's achievable, and she's persistent, and hopefully God will be kind and she'll get her medicine.
Yeah. I visited her in her home on Saturday, and she seems like a wonderful mother. She loves her children. She takes care of her house the best she can. But she's an uninsured patient. And
Now she is.
Now she is. Yeah.
And yes.
So this is what I would qualify as a good person, who cares about her children, cares about life, and yet has some significant obstacles to overcome.
Well, yes, real significant. And the legacy of her children, you know, of how they're going to grow up in a family where they see at least their father die and now possibly their mother.
Mm-hmm.
We have good drugs, but you've got to be in the system, you got to take them, you got to go through a lot of hoops.
If a patient is compliant to your treatment plan of care, what's their life expectancy?
Well, many patients I've followed for decades now. I'm one of those providers that has been following patients for a long time, and if they take their medicine, keep their appointments, usually, not always, they can proceed and lead normal lives, jobs, work, life goes on.
All right. We work in the hospital together. What is it that you would want other healthcare professionals in our hospital to know about uninsured patients that we are now seeing more of and more of here at Women's Hospital?
Well, Women's Hospital, I'm sort of one of their orphan stepchildren in a way too, from another variety of systems. But when I came to Women's, it was a very nice, predominantly private hospital, and here I was an AIDS provider with very sick, predominantly poor patients. And I've been very happy and that they've been supportive. We probably are one of the largest HIV pregnancy centers in the country, if not one of the largest. And they've been, as I say, very welcoming. I think that while patients are pregnant, they get coverage, they get emergency Medicaid, and we can, in that window, intervene. And again, the drop-off is when they're not pregnant and they take care of everyone else and may lose their pregnancy-related insurance. So I've been very happy at Women's. They've been very supportive, the nurses, the staff, Miss Russell.
Yeah.
And yourself.
Myself, thank you.
Yeah.
Is there anything else you would want me to know or would be helpful to me on this learning journey about an uninsured patient?
Well, what I'd say as an ad for Women's, we have the lowest vertical transmission rate of any hospital I think, in the country right now for HIV. And it's not a glamorous reason. It's just you get the patients in, you provide a small team of people that care, and they will take their medicine. Patients sense that. If I were to tell other providers, it's those humanistic things. You don't stigmatize patients. I make a point of shaking the hands or hugging my patients. They're not lepers. And I think those kind of things, how can I help you versus what do you want? And when you walk down the halls of the hospital, you wouldn't recognize my HIV patients from a regular patient. They look like everybody else.
One of the things you taught me, and I'm glad you brought that up, is that it's probably more of a risk for the patient to be around me than I am to be around
Right.
them. Yeah. Because their immune system is lower.
Right.
And I could carry a germ into their room, and that germ could cause them a lot of trouble.
Right, that's true. And people sometimes get this, they have AIDS, I'm going to get it. You're not going to get it unless extreme things happen. It is true, when you operate, there's sharps, there's needles, what I call the hot zone. You're a little extra precautions.
Yeah, yeah. Well, Dr. Hammill, thank you for your time, and thank you for your service and what you do for all mankind.
Okay, thank you.
Okay.